Hi everyone, my name's Jenna Ward, and today I'm going to be presenting to you guys about the gut microbiome in patients with early stage and late stage melanoma. So our bottom line up front, why should we care about melanoma? Melanoma is a type of skin cancer that begins in the melanocytes, which are these cells within our skin that produce the melanin, which is the color in our skin. And these growths often mimic benign growths on the skin, such as regular moles. But these melanoma growths can become metastatic and dangerous if they're not treated quickly because they are a very aggressive form of skin cancer. So what is being studied here is how does the gut microbiota profile differ between healthy volunteers and those with melanoma, as well as between those with early stage versus late stage melanoma. So for these patients, they were gathered from a cancer center, and the researchers collected fecal samples from them over the course of 4 years. And then after those samples were collected, they took some healthy volunteers, which were actually employees at the cancer center, and then they collected fecal samples from them. And these people were followed for recurrence for about 2 years after the sample collection, and that was the cancer patients that were previously studied. So, the connection between the microbiome and melanoma. So, before this study, very little was actually known about the correlations between the gut microbiome and melanoma patients. This wasn't really something people had thought about much or studied much. So this study was pretty groundbreaking in this field. Some statistics about melanoma that kind of highlight how important it is to study this are that the melanoma is the 5th most common cancer diagnosis in the United States, not just skin cancer, all types of cancer. And so about 100,000 people are diagnosed with melanoma every year, and in 2024, it was 100,640 cases, and 8,400 people died from melanoma in 2024. And if melanoma becomes metastatic, as described by level 3 and 4 cases, which I'll go into further later in this presentation, the 5-year survival rate for these patients is only around 35%, so that's very low. And it kind of highlights why this is such an important topic to be studying. And then in this study, they also paid attention to some of the medications that these melanoma patients were on and how those might also impact their microbiomes of their gut. And so one of the main ones that a lot of these patients were on was corticosteroids, which are usually used to treat rash, irritable bowel disease, asthma, and chronic inflammatory conditions. So a lot of these patients with melanoma also had other conditions that they were using these corticosteroids to treat. But these corticosteroids, they actually can, the point of them is to decrease the immune system from kind of attacking the body itself and causing these diseases. But this can lead to increased microbial infection, so it really impacts the microbiome. And then corticosteroids are also linked to thinning the skin and having slower healing, which really can impact these patients with melanoma. And then many of them were also on statin medications. And so many of you have heard of these. They're used to lower cholesterol. But statins are also known to have antimicrobial properties because they disrupt the teichoic acid structures and alanine residues in gram-positive bacteria, and this can reduce their abilities to form biofilms. And so this could be good in some cases, but in other cases, maybe not if it's for beneficial bacteria in the body. And so for the methodology of this study, it was a case control study with 438 melanoma patients participating, and these samples were collected over the course of 4 years from patients who hadn't been treated yet. So it was seeing like how they progressed from when they first entered the cancer center to later on. Those with early stage melanoma, there were only 38 of them with either between stage 0, which is known as in situ, which is only located in the top layer of the skin, and also through stages 1 and 2, which goes a little bit deeper into the skin but has not yet reached the metastatic phase. And late stage melanoma patients, stages 3 and 4, are when it becomes more infiltrative and can become metastatic in the body and spread to other locations other than just the skin. And for those stages, there were 141 participants, which makes sense because the study was carried out at a cancer center, and patients with early stage melanoma can usually just undergo excision type procedures where they just cut the cancer right off the top of the skin, and these people are usually fine. But once it reaches the later stage, they may need systemic treatments and much more aggressive treatments for their melanoma. And they also looked at a variety of medications that these patients were on, including PPIs, which are proton pump inhibitors that are used to treat gastroesophageal reflux disease, which is basically just like heartburn. And then they also looked at whether the patients were on statins, corticosteroids, or antibiotics. I already kind of discussed why we would care about the statins and the corticosteroids. And then for antibiotics, obviously, these would affect the microbes present in these patients and likely could impact their dysbiosis of the gut microbiome, because these antibiotics might also be killing the commensal bacteria. So these patients were followed 2 years after the study to see if they had any adverse effects and for any disease recurrence, or even if they ended up passing away due to their melanoma. And so the control patients, as I mentioned before, were employees at the center, and they agreed to have their microbial profile performed from stool samples, but they weren't aware that it was for this study specifically. And then so to identify these microbiota, they used OmniGene Gut and Illumina and to profile them, and they studied the alpha and beta diversities as well as the relative abundance of different taxa. So for that, that means that alpha diversity is the number of different microbes and the distribution of them within a sample. And the beta diversity is a measure of the difference in the microbiota between different samples. So for the first finding of this study, it's seen in this figure 1. And so it kind of just describes here like the study participants, how many controls they had versus early and late stage melanoma, and how many of stage 3 versus stage 4. So in the second figure here at the bottom, figure B, you can see how the fecal microbiome was profiled, and then from there they went on to identify the different taxa present as well as how it worked functionally. And then if there was any associations between the melanoma patients versus the control patients, and then if there were any differences between early and late stage melanoma patients. So here it kind of gets into more of the details of the findings. So based on figure 2A, we can see the alpha diversity through the inverse Simpson index graph. And this shows that there was a diversity in the alpha diversity, which was higher in controls, but it wasn't necessarily statistically significant, as you can see with the p-value of 0.06, but when just looking at the data, there was a pretty big difference, just not statistically significant difference. And then in figure 2B, you can see on this graph that between the samples within the group, there was a large beta diversity, and then the control groups, as you can see in the dark blue here, showed a difference that was distinct from the melanoma. As you can see, the centers of each of these were very different from each other. And then you can also see that They just have different species present, and then the diversity differs between the two groups. And in 2C, you can see that in this graph, we see they studied different bacteria in the Acetomycota family, including Bifidobacterium, Colonessa, and Eldercruditia, and also in the Firmicutes family, which includes Eubacterium, Hali, and Streptococcus. And these were much more present in the controls than the melanoma patients. And a lot of these are more of commensal bacteria that help to improve gut microbiome health. And in the melanoma patients, these are much lower. And so that kind of tells us how this disease might be impacting their gut microbiome. And additionally, the fusiform bacteria was higher in melanoma patients. And this is also found in other studies that when it's higher, it leads to more inflammatory conditions or other cancers progressing, such as in studies with colorectal cancer. So this might hint that a higher presence of this bacteria will lead to progression of cancers. And then in graph 2D, you can see that they studied the presence of ruminococcus bacteria, and this was significantly higher in the controls than in melanoma. And this is also more of a commensal bacteria. So this shows that these people were likely had a healthier gut microbiome that was not experiencing a state of dysbiosis. And then in figure 2E, you can see here that they used something called a pie crust analysis. And this shows how it's estimating the functional gene content based on the 16S RNA. And it's showing how different genes in this pathway are able to be more functional or less functional based on different characteristics, such as like signaling and cellular processes or metabolism, as you can see in this graph. And it's showing how they differ based on the control group in the melanoma. And you can see that the control group was much more active than the melanoma group. So in figure 3 here, we can see that these are similar graphs to the one in the previous slide, but here it's comparing early versus late stage melanoma patients. And the late stage melanoma patients studied here are known as therapy naive, which means that they have yet to receive any therapies for their melanoma. So it's more studying just how the gut microbiome is impacted by having melanoma rather than by the treatment itself. So we can see here that there's much higher diversity in the alpha diversity section in the early stage melanoma versus the late stage melanoma patients. And this just kind of shows how this one is statistically significant in comparison to the previous graph, which shows that there really is a difference between early stage and late stage. Okay, so in figure 3B here, you can see how there's a big difference between the late stage versus the early stage melanoma patients, and that the late stage patients, there are much further out lines on this graph showing less similarity in beta diversity. And you can also see here in figure C how the differences of the functions of genes are, with those in the early stage being a little bit more active than those in the late stage. In figure 3D, we can see that the Roseburia genus was the most prevalent in early stage melanoma patients, which shows that they have a higher ability to reduce the tumor burden. However, as it was seen in other studies. The Roseburia gene, once it's depleted, these patients have a more difficult time getting rid of their tumor burden. And so you can see how in the late stage melanoma patients, they have the most active lactobacillus gene. So then here in figure 4, it just is describing different demographic and clinical information about the participants. So we can see here that many more of the melanoma patients were men, which I found a little bit interesting. I'm not really sure what the scientific significance is of this, but it is interesting how there are significantly more men participating in this study than women. Um, we can see that based on these stages down here of the melanoma that I was sort of mentioning earlier, these are known as Clark's levels of melanoma. So when it's in situ, it's localized to the top layer of the skin. And then as we go up in the numbers and the Clark's level, it describes how dangerous the melanoma is for the patient. And so once we get to level 4, that is the most dangerous, and it is likely metastatic at this point, whereas in 1 and 2, it's most likely localized to the skin. And so it makes sense that for this study, most of the patients were in this late stage melanoma with the level 3 or 4, because the data was collected at a cancer center, and usually patients with earlier stage melanoma don't really need to be treated at a cancer center and can just be treated at their dermatologist. However, once the melanoma becomes metastatic, then this is more of a systemic issue rather than just localized to the skin. Another point that I wanted to point out about this data is that in the control group, none of the participants were on antibiotics, which, as we know as microbiology students, antibiotics can really impact the gut microbiome and lead to a state of dysbiosis if they are on them for a long period of time, which many of these patients with late stage melanoma, as you can see here, 61 of the 141 were on long-term antibiotics. So this would likely impact their gut microbiome in a negative way. And then we can also see that very little of the controls were on any medications at all. Like none were on corticosteroids, only a few were on statins or PPIs, but many of the melanoma patients were. And then, as I had mentioned earlier in the presentation, the corticosteroids can also impact the gut microbiome as well as statins. And with many of these patients being on statins, it makes you wonder, like, how this impacted their microbiomes and how many of these patients with late stage melanoma were on many other medications. It doesn't say that which antibiotics these patients were on or which of the patients were taking these medications, whether it be one patient taking all of them or like what the overlap was with these medications. So that makes it a little difficult to analyze the study. And then these patients, the ones with the late stage melanoma, they are more likely to be suffering from like skin wounds from their treatments. And this possibly could be the cause of them needing antibiotics. So it would just be interesting to see like how each patient's medication list corresponded with their data. And then, as we can see here in figure 5, this is the part where they measured the recurrence rates of the patients with the stage 3 melanoma. And so these patients were found to have a higher alpha diversity, but no difference in their beta diversity. And then there was also no significant difference in the taxa present in their gut microbiome related to their outcome. So this makes it difficult to say whether or not the taxa present in their microbiome contributed to their melanoma progression of their disease. but there does need to be much more research done in this field to be able to determine that. Overall, these researchers found that gut dysbiosis may be linked to melanomagenesis and disease progression of melanoma. So they believe that differences in the candidate taxa implicated in other melanoma cohorts, including the genuses Roseburia, Bifidobacterium, Ruminococcus, and Fusobacterium, exhibited dysbiosis compared with healthy controls. So many more of these late stage patients were studied, as I mentioned, due to it being at a major cancer center. So this could have thrown off the data a little bit because there was a much larger sample size from the late stage patients versus the early stage patients. And additionally, some other limitations I found in this study were that antibiotics, corticosteroids, and statins are all linked to microbial dysfunction, which makes attributing dysbiosis to melanoma difficult because it could be related to these medications and not to the melanoma at all, but it's difficult to draw this distinction based on this study. However, it does account for compounding factors that could attribute to disease progression because these researchers were stating that the dysbiosis might be linked to the progression of melanoma rather than the other way around. So there was also an interesting point that I found where there was a significant racial difference between the melanoma patient group and the control group, with 22 people in the control group identifying as races other than white, which could account for some differences in microbiota, but it's really difficult to tell based on the information given in this study. So some questions I came up with for you guys to discuss are, how do we think that these results could provide new guidance in the treatment protocols for melanoma? Because these protocols have been recently developing a lot and improving a lot, but as we saw from that first slide, a 35% survival rate for those with stage 4 melanoma is not ideal at all, so we really do need to figure out better treatment methods for these patients. And then next, to what extent were antibiotics a factor in the difference in diversity of the microbiomes of late-stage melanoma patients? And how do you guys think that identifying which antibiotics these patients were on could help us determine this extent? The third question I have for you guys is, if microbial dysbiosis leads to progression of many types of cancers, do you think that supplementing the microbiome could lead to the slowing of tumor proliferation? And the fourth question, why are medications that patients are taking crucial to the data collection and results of this study? And last, what are the limitations of this research in applying it towards future patients? Thank you guys for listening to my presentation, and I hope you guys enjoyed.